The goal of this lecture is to help students determine and assess what airway should be used based on the patient. Upon completion, students should be able to select the most appropriate airway for their patient based on the patient's needs. Today's objectives are to assess the patient's breathing. We need to determine what the patient's O2 saturation is, determine the source of the breathing problem, decide if the patient's O2 saturation can be brought up without an airway adjunct. Will medication be needed? If so, what are the doses? Will medication correct the problem? Determine if the patient needs airway management. We're going to review the airway adjuncts to include BVM, OPA, NPA, iGel, King, intubation, and crike. We'll decide which airway will be best for the patient, and we will form an alternative plan if the first airway does not work. First, we will need to assess the patient's breathing. Determine what the O2 saturation and entitled CO2 are. Listen for lung sounds. Are they clear? Are there rales, bronchi, wheezing, stridor? Can the patient's O2 saturation be brought up without an airway adjunct? So this picture here is going to show some of the probabilities for each sound that you might hear when you assess your patient's lungs. So rales will present with crackles, smaller airways, fluids in the lungs. So your CHF patients or a patient presenting with signs of pneumonia would have rales. Bronchi are going to be a larger airway obstruction of fluid, accumulation in the larger airways. So your patients with COPD or pneumonia may also present with this. Wheezing, that's going to have the largest effect on the bronchi, and it's going to constrict the bronchi. And air trying to pass through the bronchioles. So you'll see this with asthma patients or a patient with bronchitis. Stridor affects the upper airway over the trachea. So patients with foreign airway body obstruction may present with stridor. We're going to do a quick review over the waveforms that you could see with your entitled CO2 capnography in place. Your normal right here at the top. Nice, even. Hyperventilation, that's the elimination of CO2, which is going to result in a lower CO2, so the waveform will be faster and not quite as wide. Hypoventilation is going to be when your patient's retaining CO2, which is going to elevate the level of CO2, which will present with a wider, more of a plateaued waveform. So a patient that has bronchospasms are going to present with the shark fin. So this would be seen in patients with asthma or COPD. So we're going to do a quick review over our oxygen delivery devices. These are going to be the ones most used out in the field without using an airway adjunct. So your bag valve mask, known as your BVM, is going to deliver 10 to 15 liters per minute of O2 with 90 to 95% oxygen concentration. Nasal cannula can be used between 1 to 6 liters per minute, and that's going to deliver 24 to 44% O2 depending on where you have it set. The non-rebreather mask is going to deliver 10 to 15 liters per minute, and the oxygen concentration is going to be 90 to 100% depending on where you have it set. Nebulized albuterol, our dose for that is going to be 2.5 to 5 mils, which is going to be 0.5 to 1 milligram. These are known as a fish, which is going to contain 2.5 mils of either albuterol or Atrovent. CPAP stands for continuous positive airway pressure. You're going to use this at 15 liters per minute. The contraindications for this, we need to make sure that our patient is able to follow commands and is the patient in respiratory arrest. So with your BVM, you need to make sure that you have a good seal so that your patient is getting the maximum amount of oxygen that you want to deliver. With a nasal cannula, it maxes out at 6 liters per minute because if you go higher than that, it can dry out the nasal mucous membranes and it causes them to break down easily. The neb treatment is good because it passes through the upper airway to the lower airway and helps open everything up. So we need to determine what's causing the problem. Is there something caught in the patient's airway? Is it in the upper airway or the lower airway? Is the patient presenting with, CHF or COPD? Does the patient have pneumonia? Does your patient have a PE or just a foreign body airway obstruction? Is your patient just having an anxiety attack or an asthma attack? Is your patient going into anaphylaxis? And all of these, we will discuss the different treatments for each of these. Patients that have COPD or CHF and asthma should know, and you should be able to get that information from the patient. So then different medications needed to help treat each one of these. So your albuterol, as we discussed, will be 0.5 milligrams to 1, which is going to be 2.5 milliliters to 5. And again, a fish, as they call it, is 2.5 milliliters. A personal inhaler may help with asthma. Do they have an EpiPen on them? And then, will the medication correct the breathing problem? So, if they are having a PE, what do we need to do? What are their vital signs? Is their blood pressure high enough that we can give them nitro and put CPAP on them? If they're having an asthma attack, have they tried using their inhaler? Do they need a nebulized treatment of albuterol? For anaphylaxis, are they going to need the nebulized treatment with the non-rebreather mask? They may also need epi. If they have their EpiPen, that's going to be 0.3 milligrams that you're going to administer of 1 to 1,000 IM. Do they need Benadryl, 25 to 50 milligrams via IV? Possibly Solumedrol. Your dose for that's going to be 125 milligrams via IV. Do they need an H2 blocker? Do they need Pepsid? Last resort, you could give MAG to relax those smooth muscles. So we would have to determine the problem and then determine if medication is needed to help correct the problem. And if the medication does not help correct the problem, what do we need to do from here? Does the patient require us to manage their airway with an airway adjunct? Is the patient deteriorating? We can reevaluate the O2 saturation, check their end-tidal levels and their capnography, reassess lung sounds. So this protocol is pulled from the state of North Carolina. Each county is going to have their own specific protocol, but they all pretty closely mirror these. And it just walks you through, a step-by-step yes/no of what to do. If we start at the top and assess the respiratory rate and effort, is the patient breathing? Okay, well, what's their O2 saturation? Do they just need oxygen? Are they having an anxiety attack and they just need to be coached through breathing techniques? And if they're not, then go down to your basic maneuvers first. So we're going to open the airway with either a head tilt chin lift or a jaw thrust, depending on if there's trauma. Can we insert a nasal or oral airway, so an NPA or an OPA? And then can we just bag them? Will that be sufficient? So you can just kind of follow this down, and if that works, then we keep coming down. If it does not, is there something caught in their airway? Can we see it if we use a laryngoscope? Do we have our McGill forceps ready to go? And you just proceed down until you hopefully remove the object, or if you need to do a crike, then we'll go over that. And you can always call and contact medical control. If you are not sure, if you've tried everything and nothing's working, there's no shame in asking what the next procedure should be. So we're going to go over our airway adjuncts. We discussed a moment ago about the BVM. We're going to go over the oropharyngeal airway, which is your OPA, the nasopharyngeal airway, which is your NPA. We're going to go over the IGEL or King. Each county has their specific one that they like to use. We're going to go over intubation, and then lastly, we're going to go over crike. So we're going to start with the BVM. It's very important with this to ensure you have a proper seal. So you're going to use the C method. If it's just one person, you're going to use one hand to make a good seal around the face mask, and then ventilate 10 to 12 times a minute, or if you want to do one breath every 5 to 6 seconds. And if you have two people, you're going to have one person hold a good seal and the other person is going to squeeze the bag. It's important to make sure that you have the appropriate mask and bag for the patient. So in each truck, there should be a neonate, a pediatric, and an adult BVM. Make sure before you start squeezing the bag that you have performed the head tilt chin lift, or if it's a trauma patient and you do not need to move their neck, you can perform the modified jaw thrust. Anytime you're using a BVM, you want to make sure that you have either an OPA or an NPA in place. So these are things that you might see upon initial approach to your patient that lets you know that this may be a little bit difficult to ventilate. The acronym they use for this is MOANS. So you want to make sure that you have a good, are you going to have a good mask seal? Does the patient have facial trauma or facial hair that may obstruct that? A lack of teeth, or if a patient does not have their dentures in, may make this very difficult. Is there an obstruction? Is your patient obese? Is your patient over the age of 55? No teeth, again, with or without dentures. And do they have a stiff lung or sleep apnea? Do they have a history of snoring? The initial presentation, do they have a Mallampati score of 3 or 4, which we'll discuss later on during this lecture? And then another one would be severely limited jaw protrusion. That could cause a big problem getting a good seal and getting air to go into the airway. Next, we're going to discuss the oropharyngeal airway, or known as an OPA. So the top right corner of this slide is going to give you a quick glance at what these look like, which you've probably already seen before. So the purpose of the OPA is going to be to hold the tongue away from the posterior oropharynx and prevent obstruction of the epiglottis. We're going to go over some advantages and disadvantages of using an OPA. This OPA will be contraindicated if the patient is vomiting or still has an intact gag reflex. And if you're unsure if your patient has a gag reflex, you can gently touch the top of their eyelid, and if it bounces or they jump, then they're more than likely going to still have a gag reflex. Some of the advantages to using an OPA is it is very simple to place. Air can pass around it and through the OPA. It's going to prevent obstructions by the teeth and the lips. It's going to provide an easier path for suctioning because you can go down one side or the other. Some of the disadvantages is it doesn't isolate the trachea or prevent aspiration. If the person's teeth are clenched, you're not going to be able to insert an OPA, so you would probably move to an NPA, which we'll discuss next. If it's not placed properly, or if it's the incorrect size, it can become dislodged or obstruct the airway. And then, of course, if they did not have a gag reflex and they comes back and they do have one later on, of course you're going to need to remove that. So make sure you have the proper size. you're going to lay the OPA next to the corner of the mouth and then measure to the angle of the jaw. So there's multiple sizes. You should find one that fits doing that method. And then it's very simple to insert. You're going to open the mouth, inspect it. If you see anything in there or fluids, you can always suction it. You're going to grasp the jaw, and then you're going to lift to the anteriorly. You're going to insert the curved reverse or the tip point towards the roof of the mouth. And then when the tip reaches the soft palate, rotate it 180 degrees, and it should be sitting right over the tongue and hold the tongue in place. Double check that you have the proper placement, and then resume your ventilations with your BVM. This is just a quick picture that shows you how it sits into the patient, just so you can take a look at it. So next we're going to discuss the nasopharyngeal airway, or the NPA. Again, in the top right corner you can see a sample picture of various sizes. These are good because they follow the natural curvature of the nasopharynx and pass through the nostril to the posterior pharynx just below the base of the tongue. We're going to discuss the advantages and disadvantages of using an NPA. So the advantages are going to be it's quick and easy to insert. It bypasses the tongue, so you can use it if the patient still has a gag reflex. You can suction through the mouth still and not have to worry about any obstructions. Again, it gives you a good airway if the patient's teeth are clenched. Some of the disadvantages of it are going to be that it's smaller than an OPA. Again, it obviously does not isolate the trachea. And it can cause pressure necrosis and bleed if it's inserted too forcefully. It can kink or clog if you're applying too much force. And then the contraindications for this are going to be a patient that has a basilar skull fracture. So to size this, you want it to obviously be a little bit smaller than the patient's nostril, and you're going to measure from the nose to the earlobe. And then to insert it, inspect the nostril. You're going to lubricate the NPA just to give it a better sense of ease through the nostril. You're going to gently push up on the tip of the patient's nose. The beveled edge needs to be turned towards the septum. And then with the NPA directed straight back along the nasal floor, parallel to the mouth, and then gently start pushing in. Once you have it inserted, you're going to verify placement and then resume your ventilations with a BVM. So again, this just shows you a picture of how it looks when it's inserted into a patient. Next, we're going to discuss the iGel. This is going to provide you a non-inflatable seal of the pharyngeal, laryngeal, and perilaryngeal structures. This is kind of cool because it can be used as a guide for intubation, which there's a picture on another slide that will show you how you can slide the stylet or bougie through the iGel so that you don't have to remove the iGel until the very last minute when you're ready to intubate. Some advantages of the iGel, or you can suction through this. It has a built-in bite block, so once you get it inserted, your patient's teeth should rest right on there. It's going to reduce the risk of the epiglottis folding down and then obstructing the airway. There's no inflation required with this, so it's kind of a one-stop done. And it's very quick and easy to insert. Some disadvantages of this are going to be that the sizing is less flexible because it does not have an inflatable cuff. So you want to make sure that you're using the correct size, which there's going to be a chart on the next, I think, 2 slides. If a patient has trimmus or limited mouth opening, this is not going to be the correct airway. You should go with an NPA. So there's a chart that shows the general sizing, and then there's an insertion video on the next slide. If you double click on it, you should be able to watch that. And then, of course, when using this, you're going to want to make sure that you put your entitled CO2 on there before you resume bagging. So if you double click on this video, it's just a short video that shows you how to insert the eye gel. A sizing chart. Again, with these, you have to make sure that you do use common sense with this. If you look at your patient that is a 9-year-old but is built like a 15-year-old, you may need to alter your size a little bit. For pediatrics, it is important to use the Broslo tape, which should be included in all of the peds bags on the trucks. So this shows you how you can intubate through the eye gel. If you're unable to get the whole ET tube through it, of course you can just put the stylet or the bougie through it. Probably the bougie, just to make sure that you get it passed through the vocal cords before you remove your eye gel, and then you can just slide the eye gel down this way over your bougie, still in place. Slide your tube right over it, inflate the cuff. Next, we're going to discuss the King LT. Pictures in the top right corner, just giving you a quick glance of what that looks like. So this is going to stabilize the airway at the base of the tongue and minimize the risk of injury to the trachea and vocal cords. This can also be used as a guide for intubation. It would work the same way, where you could put your bougie down through there, get your placement, get everything ready to go before you pull that King and go in to intubate. We're going to go over the advantages and disadvantages of the King. So the advantages are it's more flexible because it has the inflation cuff. It gives you a little bit more flexibility. It's smaller than the old combi tube that used to be used on trucks. It does have multiple outlets for airflow, which is nice, and it can be quickly deflated to intubate if you need to. So if you've already inserted your bougie through your King and you are ready to remove the air, you can simply hold on to the airfill port and then pull the blue end off. That's going to deflate your cuff so that you can slide your King back up and over your bougie and go right into intubation. The disadvantages of the King is it requires 60 cc's of air to inflate that cuff fully. So it's going to take a little bit more time than your eye gel. There's going to be a video on the next slide that's going to show you how to insert the King. And of course, if you're putting the King on, make sure you put your entitled CO2 onto the end of the tube before you resume bagging. Quick video, if you double click on it. This is going to be your sizing. Again, make sure that you're using the Broslo tape for your pediatric patients, and also use common sense when you look at your patient and see the size of them. So these are going to be some things that may make it difficult with an extraglottic airway, which would have been the ones that we've discussed. So your NPA, OPA, your eye gel, your King. They use RODS as the acronym for this. So limited or restricted mouth opening. Do they have some obstructions, which could be secretions? Are they obese? Do they have severe pulmonary disease or distorted airway? Do they have stiff lungs or spine? The pathology is below the device. So do they have inhalation burns? Is there laryngeal trauma or angioedema that you're not going to be able to necessarily see from the outside when you're viewing into the mouth? So now we've come to intubation. This is going to stabilize the airway by providing oxygen directly into the trachea. It provides optimal protection against aspiration. It is a little more high risk with more complications from the previous airway adjuncts that we've discussed. It does require all of your equipment listed here. So you'll have your laryngoscope with either the Mac or the Miller blade, whichever is your preference. The tube, you're going to use a stylet or a bougie, and then a 10 ml syringe, and then of course the tube holding device, which is going to secure this tube to the patient. Go over some indications and then contraindications of the tubes, of using the tubes. Some of your indications are going to be the patient has inadequate oxygenation or ventilation due to an upper airway obstruction. respiratory failure, or a loss of consciousness and not maintaining their own airway, difficulty with ventilations with a previous airway adjunct, or these are used a lot with cardiac arrest patients. Your contraindications are going to be, obviously, if the patient has a gag reflex, we do not want to intubate them. And it's more likely to cause a laryngospasm or C-spine injury. So I mentioned that this was high risk with some complications. So it's a lot of times it prolongs the on-scene time. If it's not done correctly, it could cause trauma to the airway or potentially cause your patient to become hypoxic. This has a cuff that inflates, so there's always the risk that your equipment could fail or not work properly. So before the tube is inserted, it needs to be tested to make sure that the cuff will hold air. And then always confirm your tube placement by checking your lung sounds and using entitled CO2. This is just a quick video again that shows you how to intubate the patient. You can double click on this. So these are going to be your tube sizes. Again, with this you have to use common sense and your own judgment when you're deciding what tube is going to work best for your patient. You do have a little bit more flexibility again because you have an inflatable cuff with this. And just remember, with pediatric patients, use your Broslow tape. This also gives you the size French cath that will be used for suction should you need to, so it can be a quick reference so you can have that on standby. So difficulty with intubating patients can be remembered by the acronym of LEMON. So you're going to look externally. Do they have facial trauma or abnormalities? Evaluate the 3-3-2 rule, which we are going to go over on the next slide. Do they have a short thyromental distance or a short sternomental distance, which is seen on the figure to the right? Your minimum distance for the thyromental is going to be 6 centimeters, and then for the sternomental is going to be 12.5 centimeters. Do they have a limited mouth opening? Is the neck mobile? Is it stiff? Is the patient obese? This always presents with a harder time intubating. Does your patient have buck teeth? So this is the 3-3-2 rule. You're going to use the patient's fingers to take these measurements. So if you're not able to move the patient's hand, obviously you can just set yours down there, get a good gauge on the comparison. So you're going to want 3-finger mouth opening, 3-finger right under the chin from the mentum to the hyoid bone, and then 2 fingers from the floor of the mouth to your thyroid cartilage. Previously, we had mentioned the Mallampati score. The picture to the right is going to give you a good visualization tool for what you will see when you're opening the patient's mouth. And they fall into 1, 2, 3, or 4 as the classifications. So class 1, you can easily visualize the soft palate, the uvula, the anterior and the posterior pillars. So this should be a pretty easy, straightforward intubation. Class 2 is you can visualize the soft palate and the uvula, but it may provide you a little bit of difficulty while you're getting ready or intubating. Class 3 is a visualization of the soft palate and just the base of the uvula. So that's going to be more difficult. Class 4 is going to be only the hard palate or the roof of the mouth is visible. So that's going to be an extremely difficult intubation. You may need to be a guide and use your bougie to get in through the vocal cords. And it's always important after intubating, whether it's successful or unsuccessful, to document the patient's Mallampati score in your PCR. So our patient has a failed airway. So what are we going to do now? Again, this is pulled from the North Carolina state protocols. They define a failed airway as inability to ventilate and oxygenate less than 90% or greater after 2 or more failed intubation attempts. These attempts should be attempted by the most experienced provider, which a lot of times is difficult because students or new medics are eager to do this and to train on the skills and do it on live people. If you've attempted once or twice, the most experienced person should definitely make the 3rd attempt. If you're unable to maintain adequate O2 saturation of 90% or greater with the BVM and insufficient time to attempt an alternative maneuver, or the patient is near death or dying. So you can see the progression on this. In the top right box, it's going to go over the definition by the state of North Carolina. So you have a failed airway. We're going to start with the easiest and the simplest. Can we maintain that patient's airway with either an NPA or an OPA and bagging the patient? If you can, then you're going to come off to the box to the right. If not, you're going to come on down to figure out, is there facial trauma or swelling, which if there is, then you're going to come over to the left box with the blue P, and we're going to need to move towards doing a crike. If you don't have any facial trauma or swelling, come on down to your airway biad procedures, which will include your King, your iGel. Was that successful? If so, that's great. Then ventilate the patient. If not, it points you right back up to a crike, which we'll discuss later. If you're getting down to the point that you're in the last box and you're not able to ventilate the patient, you need to be calling and getting directions from medical control. Again, there's no shame in calling. If you can't step out, you can have somebody else on scene or your partner call in. So next we're going to discuss a crike. This is going to provide oxygen to the trachea via a small incision through the cricothyroid membrane. So to see it on a patient, especially with men, it's fairly easy to find because of the Adam's apple. So you can see the really pointy part is your thyroid prominence, and then down below that's going to be your other little bulge is going to be your cricoid. So you're going to feel right in between there, and there would be a soft place. So you can also see it over to the right, broken down a little bit more. This is considered a last resort, so if you're doing this, someone should be calling medical control. Some of the indications for doing a crike are going to be you have been unsuccessful getting the O2 saturation up with a BVM, or you're meeting a lot of resistance. If you're unable to place an ET tube, either orally or nasally, this should be where you're going. If there's a complete upper airway obstruction from the epiglottis or from a foreign body, if your patient's in severe anaphylaxis, has burns to the face and respiratory tract, this would be a good adjunct to use. Some of the relative contraindications for a crike are going to be that you're unable to identify the landmarks. So you want to make sure that you go right into the cricothyroid membrane as opposed to the trachea, because the time for healing for the patient, if you go through the trachea, is going to be much longer than if you go through the cricothyroid membrane. If the patient has crush injuries to the larynx, you are not going to be able to do this. Or if you suspect a tracheal transection, or if there's underlying anatomical abnormalities, this is not going to be the way that you need to go. Again, a quick video just to demonstrate the skill. Double click on that, and just a couple minutes long. So some of the difficult crike placements, people will use the acronym SHORT for. Do they just have surgery? Hematoma? Is the patient obese? Radiation or a tumor? Some of the reasons that the cricothyroid membrane is not easily located could be from obesity, trauma to the anterior neck, prior radiation therapy, Ludwig's angina, which is a skin infection to the anterior of the neck. Another issue is the tube insertion prevention, because you do have to make a small incision and then insert a tube into the patient. If they have tumors, an infection, there's swelling, there's a foreign body that is lodged in there, you will need to contact medical control and move quickly towards a trauma center or a hospital. So the most important thing while you're doing all this is to make sure that you have a backup plan. If you're inserting an OPA, you should have a iGel or an ET tube or a King ready to go in case that OPA fails and you're unable to ventilate your patient. Same thing with the NPA. If you're inserting an NPA into a patient and bagging them, what are you going to do next? Where do you go from there? Why did you choose an NPA over an OPA? Are you going to be able to move to intubating your patient? So you should just always have a backup plan. Never be afraid to call medical control and get guidance on any of these issues. Calling and getting guidance is better than failing and losing a patient. So we've discussed all of the airways that can be used to help manage a patient's airway. Start simple and then progress through the complex nature of some of these. And again, call if you have questions and contact medical control. So a little scenario. You're dispatched to cardiac arrest. When you arrive, fire is already on scene and with the patient. When you enter the house, you see a middle-aged man lying supine on the floor. Fire tells you that when they arrived, the man was unconscious, pulseless, and not breathing. Fire started CPR and has been doing compressions and providing ventilations via BVM with minimal resistance for the last 3 minutes. The second unit is still about 5 minutes out, so we need to decide how we're going to secure this patient's airway. So for this patient, they need a secure airway that's going to stay in place while compressions are being done, either manually or with a device, like a Lucas device or something like that. So you're going to want to make sure that the fireman continues to bag the patient. You need to prep all of your intubation equipment. So you need to make sure that you have the laryngoscope with the blade of your choice, either a Miller or a Mac, that your ET tube is ready and that you have checked to make sure that it does hold air, a stylet or a bougie, depending on which one you prefer when you're doing intubation, your 10 mil syringe, and then the tube holding device. So once you have all of your equipment checked, you'll have the fireman stop bagging, intubate the patient, inflate the cuff, confirm placement by auscultating your lung sounds, and make sure that you do not have any air movement over the epigastrium. Secure the tube with the tube holding device. Attach your entitled CO2 and continue ventilating the patient. Remember that this needs to happen as fast as possible to make sure that the patient's time without oxygen is very minimal. So another scenario, you're dispatched to a local elementary school for a 22-year-old female with difficulty breathing. When you arrive, the patient is complaining of breathing difficulty and says that it feels like her throat is closing up. She also states that she's allergic to nuts and just ate a cookie that she was told afterward contained nuts. She has a prescribed EpiPen but has not administered it yet. Her medications that she takes daily are birth control, and her allergies are to nuts and bees. The patient presents with cool, pale, and clammy skin. Radial and carotid pulses are both palpable, and she has symmetric chest rise and fall. Her initial set of vitals are her BP is 110/70, her heart rate is 105, her respiratory rate is 40 and shallow, Her SpO2 is 90%, and her lungs are her wheezing in all fields. So what do we need to do to treat this patient before she becomes critical and unconscious? If the patient has her EpiPen in her purse or right there, and you're able to get to it quicker than drawing up Epi, go ahead and administer the EpiPen to the patient in her outer thigh. Have someone start hooking up a nebulized albuterol treatment to put onto the non-rebreather mask. So you're going to use 2.5 to 5 of albuterol, and then you're going to turn the non-rebreather mask on to 15 liters per minute. You're going to want to establish IV access as soon as you have the mask onto the patient. You're going to administer Benadryl between 25 and 50 milligrams via IV. Solumedrol should be next, and that is going to be 125 milligrams IV. Also suggest doing a histamine 2 blocker for later on. This will be useful, which could be Pepcid, 20 milligrams. Usually PO if the patient's able to do so. With this patient, it may need to be later on when she's able to swallow with ease and does not feel like her throat is closing up. If you feel the need, you can administer 2 grams of mag sulfate, which is going to relax her smooth muscles. And you're going to want to get this patient stable and transport as soon as possible. So let's say that the medications don't work and she becomes unconscious. Make sure that you've thought far enough in advance to be ready to provide air to this patient manually. With a patient like this, it's going to be difficult to intubate, especially if her throat is completely closed up. So you're going to be going back to your Malin-Patty score. It's going to be a little bit more difficult, and you're probably going to be looking at a class 2, 3, or possibly even 4. So you may not be able to get the tube in with the stylet. You may have to pass the bougie first. But just make sure that as you're prepping all this, that you have a backup plan in your head. Start with the medications. Hopefully this works. If not, then make sure that you can quickly get air to your patient. So after this lecture, you should be able to assess and determine the patient and the needs of the patient based on their signs and symptoms, their vital signs, and then you should be able to determine the best way to manage this patient's airway. Again, sometimes there's no adjuncts needed at all. They may just simply need some oxygen through a nasal cannula at a couple liters per minute, or they could need a non-rebreather mask, or a patient with CHF or COPD may need CPAP because they're used to using their CPAP. But just make sure that you're doing what is best for the patient.